Ready now.
Good morning, everybody. I'm delighted today to introduce Dr. Sara Karp, who's been a colleague of ours at the Institute for Family Health for over 9 years. She serves as the Associate Program Director for the Icahn School of Medicine at Mount Sinai's Downtown Residency Program in Urban Family Medicine, and is a respected faculty member who has earned the admiration of her peers and has become a role model for the numerous students and residents that she teaches. In 2016, Dr. Karp was awarded Mount Sinai Institute for Medical Education's Excellence in Teaching Award, which is a real honor. She serves as a faculty coordinator for the practice management curriculum and as a resident advisor, and also chair of the program's clinical competency committee. So before joining the Institute for Family Health in 2011, Dr. Karp was a faculty member at Tufts University Family Medicine Residency Program, where she served as that residency's director of predoctoral education. Dr. Karp's interest in women's health has spanned her career. She's an instructor for the ALSO course, Advanced Life Support and Obstetrics, and also for the course on neonatal resuscitation. Today, she's going to speak to us about important updates in cervical cancer screening guidelines and recommendations on the management of abnormal results. And it's a great, great way to start our academic year of grand rounds. So thanks so much, Sara. It's all yours.
Thank you. Good morning, everyone. Thinking about this date, I just wanted to take a moment to acknowledge 9/11. It always seems a little strange to have a normal day and give grand rounds. So I've been thinking about that. We're going to talk about some updated guidelines, why we're having this conversation, and try to give you guys some practical tips of how to incorporate these new guidelines into your work. Next. Next slide, Autumn. A large credit to this talk goes to Dr. Chris Emily McCrory, who's faculty at the LS Family Medicine Program. About 2/3 of these slides are from a talk she gave. Additionally, Dr. Zeligs of GYN-ONC at Mount Sinai had given a grand rounds for their department in May, and she shared her slides, and I incorporated a few of her slides as well. In terms of disclosures, I don't personally have any. My husband has a long list of disclosures, but none of them relate remotely to PAP smears. In fact, my husband is giving the GI department grand rounds right now, but our audiences really don't overlap much, so we are all good. Next. So I'd like to talk about the different cervical cancer screening strategies and some possible changes that we may be making, discuss the rationale management updates for handling abnormal pap smear screening results, and then give you some screenshots and practical use of the new app so that you're able to create a management plan for patients with commonly seen abnormal screening results. Now, the ASCCP stands for the American Society for Cervical and Colposcopic Pathology, in case you're wondering. Many of you probably have the 2012 app, and we'll talk about what's going on with that. Now, what this isn't is an overview of cervical cancer. If people are interested or have questions, I can certainly talk about statistics and incidence. There's major issues with equity and disparities in screening and treatment of abnormal PAPs, but that's not going to be the focus of my talk, but I'm happy to answer any questions people might have. So why did this come up for me, and why did this come up for the ASCCP? So in the wonders of social media and the network of family doctors I've met through some Facebook groups, this Dr. McCrory at the LS program in Schenectady had posted in a group I'm in and said, hey, I gave a 30-minute talk on the new guidelines. Would anyone like to have a link to it? And I was like, oh, wait, yeah, there were some new guidelines, weren't there? Because in the midst of the pandemic, this new guideline came out. So why were the guidelines updated? So the ASCCP has worked with the National Cancer Institute, and over the past 20 years has done an update to their guidelines, maybe every 5 to 6 years. The 2012 guideline was the one where we really moved away from the annual pap smear screening, and where the newly recognized role of HPV was incorporated into the guidelines. You know, it was a little cumbersome. There were those 20 PDF, you know, the PDF had 20 pages of algorithms. And as soon as the technology or the tests or the thinking changes, the guideline became out of date. So in 2017, the two groups got together to start to update the guidelines and try to come up with a way to have them be useful and updatable without a major overhaul. Next. So this is the article that came out actually in April. I don't know if any of you are reading the Journal of Lower Genital Tract Disease, but that's where it came out. I am happy to share the link to the article with everyone. I will mention that there is a one-page summary of the key changes. So the article, even if you don't want to read it, is worth having for this one table that kind of succinctly puts together everything you want to know about what's changed. So HPV, we know, causes almost all cases of cervical cancer. And a moment to remind you that our PAP only tests high-risk HPV. It's a pretty common error people may make in interpreting PAPs. Those of us who are older remember years ago, we used to test low-risk HPV. So low-risk HPV, which causes genital warts, has no role in cervical cancer. So if on a pap smear report, you see the word detected for any type of HPV, it is high-risk HPV. Now, this table talks about 91% of cervical cancers being linked to HPV. Actually, if you look, it's really over 99%. And the few that aren't, there's some thought that maybe HPV was causative, but then was cleared. So really, it's a majority. A reminder that oral cancers are closely linked to HPV type 16. That is a concern for patients with HPV 16. The problem is, what are patients supposed to do with that information? So it's very challenging. And then anal cancers are significantly linked as well. Next one. So a reminder of what we're following. So the U.S. Preventative Services Task Force in 2018 updated their guidelines. And for the first time, ACOG and USPSTF guidelines align. So this is for both of them. We start at age 21. Why don't we start earlier? So the incidence of significant CIN3 or more in 20 and under is estimated to be about 0.2%. The false positive rate of cytology is about 3.2%. So doing pap smear screening before 20, except in certain very selected populations, does more harm than good. You do unnecessary colposcopies, biopsies, and you're likely to intervene on things that don't need treatment. For age 21 to 29, we're doing the cytology reflex HPV every 3 years. For 30 to right up to 65, you actually have 3 choices. You can do the cytology reflex HPV every 3 years. I think we tend to forget this option because we're sort of all doing the every 5, but you do have some patients who are really upset or anxious about going to every 5. You can offer them every 3 years and do cytology reflex, but then you need to be really careful. Your problem list needs to say that's what you're doing. And in EPIC, you have to modify your health maintenance modifier. So they fire for cervical cancer screening every 3 years. So what we generally do is the co-test. Probably people are familiar with that. And equally valid right now is primary HPV screening. It gets a little confusing when you start reading about it because there are older articles that are just HPV screening, and then there's a blanket HPV screening with reflex cytology. The Women's Health Committee at IFH is discussing this. Right now, our smart sets don't include this. And in fact, our quality scores and all that wouldn't be satisfied by primary HPV screening. But we'll talk more about that. We stop at age 65, knowing if they had adequate screening, which is 2 negative co-tests in the past 10 years, at least one of which has to be in the last 5 years. So if you're seeing a woman who's 65 and she's had no PAP, she doesn't get to start. You can only confirm one negative co-test. She doesn't get to stop. She only gets to stop if she's had 2 negatives in the last 10 years. Now, go back one for a second. So the one thing that you should know is that the American Cancer Society screening guidelines are different. The American Cancer Society actually says at age 25, start co-testing everyone every 5 years. And I couldn't really find a lot that supported that. There's even some literature that suggests, whoops, we lost our slides, I think. There we go. There's even some literature that suggests if you start screening with HPV at 25, you increase the number of colposcopies without increasing CIN3 detection and in fact causing harm. So I couldn't find a compelling argument. There is a 2018 AFP article that I thought was a little confusing in that regard as well. Okay, next one now. So the primary HPV screening, let's talk about that because it is quite possible that's the way we're going to end up going. First of all, they've studied any testing that includes HPV testing, whether it's co-testing or primary HPV, is better at detecting CIN3 than cytology only testing. So if you compare primary HPV screening, so you don't do a PAP and an HPV, you do an HPV and then see what it shows. It's higher rates of detection of CIN3, but a higher false positive rate, particularly for CIN2, and you do more colposcopies per case detected. So that's HPV, primary HPV screening compared to cytology. Additionally, there's only 2 FDA approved tests for primary HPV screening. One of them is the Roche Cobas, which is what BioReference does. The other is called Unclarity. So if a place is moving to primary HPV screening, it needs to be one of the FDA approved tests for that. There aren't any studies right now head-to-head primary HPV testing versus co-testing. So I don't know yet if we have a compelling argument for switching at this point. Next. So here is an example of how primary HPV screening would work. This is from a 2015 article, and there's a similar adapted algorithm of this in the AFP article from 2018. You would do your primary HPV screening, which, by the way, in general, you would collect the exact same way you do a PAP. So you're going to have a speculum, you're going to do your brush, you're going to send it off to the lab. And if we have time, we'll maybe touch on this question of self-testing as well. So you would do this, you would do your, I won't say you'll do your PAP, you'll do your cervical sampling. It would be tested for HPV. If it were negative, you're done. If it was positive for one of the high-risk types that isn't 16 or 18, it would reflex to cytology, and that would determine what you would do. And there's sort of the very top where it says 16, 18 positive, either that person would come straight to colposcopy, or it would actually be better to reflex the cytology, and the reason why will become clear. So this graph from 2015 is doing straight primary HPV screening, whereas probably HPV screening with reflex cytology is a little better, as we'll talk about. Next. So again, why did they make this big change in the guidelines? So, oh, that's really weird the way the graphic showed up there. The top one says simplicity. So the idea was that to avoid these 20 pages of algorithms, to simplify things. The second thing was the adaptability. The hope was that by really coming up with a model that looked at risk, that any new test or any new technology could be added to it without having to, completely redo the guidelines and make us all buy a new app in another 5 years. The last one says equal management for equal risk. We're going to talk about the whole basis of this new algorithm is the idea of risk. Next. So, oh my gosh, I don't know what happened to the translation on these slides. Well, I hope you enjoy this lovely, bizarre graphic. So the National Cancer Institute, again, the other bizarre thing about this graphic is the National Cancer Institute is on the left, and for some reason, it's all male-looking cartoons. On the right is the ACP, and for some reason, it's all female-looking cartoons. I have no idea why. But what this is supposed to tell you is that the National Cancer Institute and the ASCC got together. They then formed a panel with 20 advising organizations, which did include the AAFP, as well as ACOG and other organizations, to come up with the new recommendations. If we end up with a lot of weird slides like that, we can switch to the one on my laptop, but I think that should hopefully be it. So who does this guideline apply to? Anytime you're looking at a guideline, you want to say, does it apply to the patient in front of you? So this guideline applies to anyone with a cervix. So it could be a cisgendered woman. It's irregardless of her sexual activity. It's irregardless of her sexual orientation. And I want to add a little side note, which is right now, it's irrespective of whether the person has had the Gardasil vaccine. You know, as the Gardasil vaccine becomes more prevalent and HPV rates go down, that may lead to a change in some of the screening, but for now it doesn't matter. This applies to transgender men who have a cervix. This applies to non-binary or intersex individuals with a cervix, and individuals who used to have a cervix, but it was removed because of CIN 2-3 or cancer. So, you know, as always, don't make assumptions about the parts people have, because if they have a cervix, they may need screening. And, you know, there's also the occasional person who had a hysterectomy for benign disease, but had a so-called supracervical hysterectomy and may still have a cervix. So you've definitely got to sort that out. The other thing is these are really screening guidelines, and we'll touch base on some of the instances in which you're no longer screening, you're doing surveillance, and that's important as well.
Dr. Karp, there's a question if there's any relation to sexual activity.
Well, there is when you think about the risk factors for cervical cancer. So younger age at first intercourse, younger age at first full-term pregnancy. You know, before we had HPV testing, the risk factors for cervical cancer, you'd say, how many sexual partners have you had? How old were you when you first had sex? All of those things are really just a marker for exposure to HPV. You know, 90% of people get HPV in their 20s, 90%. And about 90% of them clear it in between 6 and 24 months. So it relates to sexual activity in that sense. Now, sometimes you will have a patient who has a cervix who's never had any sexual contact and maybe even has an intact hymen. Technically, they should still be screened. And that may be where this self-screening may come in to be really useful, but their risk is exceedingly low.
Thank you.
Hopefully that answers you. Let me know if it didn't. Next slide. So a little reminder for those for whom the histology and pathology are distant past. On the left side of this diagram, you've got your normal squamous epithelium. You know, at the bottom, the cells have nuclei. At the top, they don't. At some point, you get HPV infection. The HPV replicates, begins to shed and become infectious to spread to other people. And then the cells begin to become dysplastic with, you know, on a cytology or pathology, size of the nuclei and, you know, all of that crazy stuff. When we're talking about CIN, you see on the bottom, just a reminder that cervical intraepithelial neoplasia. 1 is mild or also called low grade. 2 and 3 are more severe, and they have to do with how much of the thickness of the epithelium is involved in the abnormal cells. By the time you're up to CIN3, you're up to at least 2/3 of the epithelial thickness. And then, of course, at some point, if it breaks through the basement membrane, that's invasive cancer. On all of this risk model that we're talking about, it's really the endpoint they're looking at is CIN3, because that is the immediately precancerous or even carcinoma in situ. So that's what you want to avoid. So the whole premise of this is that rather than looking at a particular PAP result and saying, oh, ask us HPV positive, do this. It's saying, what is this individual person's who has a cervix, what is that person's risk of CIN3 based on their age, based on their current PAP, and based on their history. Let's go a little into some of the clinical scenarios. So the first thing is, what are the contexts in which we're doing a PAP? what are the different scenarios? So that's the first thing that this new app asks you. The old app, you know, you just put in their age and their PAP and said, what do I do? So next. So there are 5 conceivable scenarios in which you're going to pull this app up because you're not sure what to do. Oh my gosh, I can't believe this graphic didn't show. All right. Yeah, that's really wonky. The others are all good. It seems to be the things in the squares, I guess somehow the translation from one modality to another. I am going to tell you what they are, but maybe we can, at the end, I can flip to the one that I have on my laptop and just show you this. So we'll just talk it through. So the scenarios are a new abnormal PAP result. So you did a screening PAP on someone with no history of any problems. You've done a PAP and it's abnormal, and you want to know what to do with an abnormal screening result. The next one is someone who had an abnormal. They didn't need a colpo. You brought them back a year later, right? They're on a shortened surveillance. And now this is the second time you're bringing them back and you want to know to do with the PAP. And I'll give you an example. You had a 23-year-old with ascus HPV positive. You brought her back in a year to see what's going on. And now you're like, okay, she's on a shortened surveillance. What do I do with the new PAP? The next one is one that only those of us who are colposcopists will probably use, which is interpretation of a colposcopic biopsy. So you guys generally probably won't use that unless you're curious, unless you're doing colpo with one of the colposcopy attendings. The next one is follow-up post-colposcopy for someone who didn't need treatment. So this one you guys will use a lot because you'll have someone who one of us did a colposcopy on last year. Maybe we didn't find anything much. They come back and see you. They're getting their follow-up PAP and co-test PAP and HPV a year later. And now you have a result and you're like, well, now what do I do? So you're going to go into this. It's called follow-up post-colposcopy. And then the last one is follow-up post-treatment. So people who have had a LEEP, a cone, cryo would be pretty unusual. So generally it's LEEP or cone. So the whole framework begins from this point. Why did you do the PAP? Because that's going to tell you what you need to do. So then the next thing is, based on what you input, it's going to give you some different options of what possible outcomes the app is going to tell you. So next one, and happily this one worked. So it may tell you, great, your person with a cervix goes to routine screening based on their age. Or it may say, oh, this person needs a 3-year follow-up. Now, maybe that person was on a 3-year interval anyway, but maybe it's a woman who's between 30 and 65 and should have been on every 5-year, but whatever this result is brings her to a slightly shortened interval. It may tell you a 1-year interval, or it may tell you expedited treatment, and we'll talk more about that later. So what about the risks? So they took, how did they figure out the risks, right? What determined it? So Kaiser Permanente, you know, huge HMO, a lot of covered lives, 1.5 million patients monitored for over 10 years. They were doing every 3-year co-testing at that time. So that's a lot of numbers and a lot of data. Let's see, hit next, I think. Oh, there we go, good. So, but does it apply to our patients? Do a bunch of Californians apply to the patients we see? To ensure generalizability, they did look at 4 additional, more diverse screening programs. It included the New Mexico HPV and cervical cancer screening, as well as, I think it was the National Cancer Institute data, and apparently the data were validated. And then they used different systematic reviews to look at some of the less common scenarios. So how do we then apply this risk model to clinical actions? The key point is that identical results do not carry identical risk. And I think we all actually know this intuitively. You know, if I said to you, I've got a 26-year-old who never had an abnormal PAP, she's got ascus HPV positive, you'd be like, okay, good. If I said to you, I've got a 39-year-old who had a LEEP 6 years ago for CIN3, hasn't been back for follow-up and has ascus HPV positive, her you're a little more worried about. So I think we intuitively know this, but this is trying to give us the tools to know. What's really kind of amazing about this, it turns out if someone has a new abnormal result and had a negative co-test 5 years before, their likelihood of CIN3 is 50% less than someone who didn't have a negative co-test before. So I'll say that again. New abnormal, if they had a negative co-test 5 years ago, they have half the risk of CIN3 of someone who didn't have a negative co-test. And if they had just a negative cytology before, it does not confer that same benefit. So I'm going to show you this graphic. We're going to see another version of it again, but this is really the mental starting point for what this app is doing. The app is really trying to tell you what is the person's immediate risk of CIN3. That is the starting point. If based on that person's current past PAPs, they have a risk of CIN3 of more than 4%, the app is going to take you to colposcopy. So you're going to put in the results, it's going to pull it up, and it's going to say colposcopy if the predictive value of their test is 4% chance of CIN3 or higher. So that's the yes or no, and then we'll break down the yeses. If, based on the patient's results, their immediate risk of CIN3 is less than 4%, they don't need a colposcopy, and what the app instead is going to tell you is what their 5-year risk is. So we're going to now look at this a little differently, and we'll continue to see this graphic, and a version of this graphic is in the app. So next. So this is the graphic you'll see in the app. I think it's a little cleaner than the last one. So again, if their immediate risk for CIN3 is somewhere between 4 and 100%, it's going to take you either to colposcopy or actually possibly to treatment. On the other hand, if their risk is less than 4%, then it's going to base how soon they need a follow-up on that risk. And the app, interestingly, is going to tell you what the person's 5-year risk is. What's been interesting about this is now that, we've started to apply it, so on Wednesday, I started looking at my schedule for Colpo on Thursday, identified a patient who wasn't going to need Colpo. And so now we're having conversations with women who we said, you need a Colpo. Oh, wait, you don't. And I'm literally showing patients, this is your risk in 5 years. This is why you don't need it. And people, people then find it helpful. I had a patient yesterday who what she was worried of was, it was some app from an insurance company that was trying to save money on colposcopy. But when I showed it to her and she saw her wrist, she's like, oh, okay, I won't do the colposcopy. So where do the percentages come from? So it turns out you can, if you want, there are 5 different huge Excel spreadsheets of data for the 5 scenarios, the screening, the post-colposcopy, all of that. If you wanted to, you could go into those Excel spreadsheets and look things up. I personally don't want to. So next slide, don't panic. There's an app for that. So the ASCCP, so you cannot use the old app. It's so completely different that the old app is garbage. And in fact, if you use the old app, you're going to get to interventions you don't need. So it is $10. Now I have good news for the residents. Dr. Coleman has said that the Institute is going to pay for the app for residents. We just have to sort out how. We're trying to find out if there's a way for us to get an institutional license for all the clinicians. So if you haven't gotten it, sit tight. You do need it, but more to follow. So for the rest of the talk, a lot of these slides are going to be taking you through the app and showing you what you see. I think it's useful, but I want to hear from people if the graphics aren't working or it's not making sense, or interrupt me if you don't see what happened, because this is really kind of the practical piece. If some of you have the app, you're welcome to kind of follow along in your app and see how it goes. So let's take a scenario of a 27-year-old cisgendered woman, Gravida 1, Para 1. She's here for her routine. She had a normal screen 3 years ago. She has no symptoms. By the way, I didn't talk about symptoms before. Remember that this guideline is about screening. If you have somebody who had a normal PAP 2 years ago, but they're coming in with abnormal vaginal bleeding or a problem, they may need a PAP at a shortened interval. So this is remember, the screening is really just the people without symptoms. So that's really key. So this lady has no symptoms. She has no additional past medical history. Next one, Autumn. So you will open up the app, and this is the screen that you will see. You can see there's an area to select the patient's age. And then here are those scenarios that you couldn't see on that wonky graphic: management of screening results and the other ones. So for this patient, next slide, we're going to tap on, so look at the left-hand screen. She's 25 to 29, and it's management of screening results. We hit the next, it takes us to the next screen, and then you're going to put in her PAP. So her current testing is HPV. Now this graphic shows it as untyped. You know, our lab types it, so I'll show you some other views later. She has ascus, and we're going to hit next. And then it gives you on the left-hand side, it's always going to give you a summary screen before it gives you the interpretation. It lets you stop and look and make sure, yes, this is the scenario for this patient. And then it would take you to the final screen, and you can see for this patient, the recommendation is colposcopy. And there's that cool graphic, and it's pretty small print. What it says is immediate risk of CIN3 is 4.45%. So she passed the 4% threshold. She needs colposcopy. Oh yeah, there, it gives it on the bottom a little easier to read, immediate risk. So that is what it looks like. Now, what I'm gonna do with this patient is now take you through the pretend year after year so you can see how we will enter the app and pick a different choice. So let's go to the next one. So let's say now our patient has colposcopy and we're gonna give her pretty normal results. So there she is, she's 20, so this is, she's had her colpo. So we say she's 25 to 29. This is evaluation of her colposcopic biopsy this time because she just had her colpo. We hit next. So let's say her colpo was totally normal. We found nothing. She had no CIN. And then it's going to ask you, why did you do the colpo? In her case, it was ascus. So you'll say next. You'll go to your summary screen on the right, and you can see that we're doing evaluation of a biopsy with no CIN. Her PAP before it was ascus. What do we do now? We do PAP and HPV in a year. And by the way, the one thing that really, you know, that you may have memorized that really hasn't changed is post-colpo with CIN1 or less is always just going to be co-test in a year. So not too big a concern. Okay, next one. So now she comes back a year later. You're doing her 1 year post-colpo PAP. So this, now we're selecting a management of results in post-colposcopy surveillance. So remember, each time it's the context of the result. That's really what matters. So you can go ahead. So again, we're going to put in her current testing. Let's say she is ascus HPV positive again. So now it's saying, this is the one area where I think when I started using the app, I got a little confused. Do you see under the ascus result where it says, does the patient have previous results since her last colposcopy? So this is really saying, after her colposcopy, do you have just the one PAP you did now, or is there another one? So in her case, this is her first PAP post-colposcopy. So we put in no, there's no other cytology results. What did her colposcopy show? No CIN. And then on the middle screen, what was her PAP prior to the colposcopy? So again, it's assembling all of this patient's data to determine her risk. You hit next, it gives you the summary screen of all, make sure you got what you wanted, you hit next. And this is the big change, right? My residents know I have like drummed into everybody, any abnormality post-colpo brings you back to colpo, doesn't matter what it is, anything. That's no longer true. Why is it no longer true? So look at her 5-year risk of CIN3. The 5-year risk is 6%. The 1-year risk is so low with a negative prior colpo and only ascus on the PAP that women who we would have been colpoing every year get a 1-year reprieve. And it's really important to look at because, as I said, I had one patient yesterday who didn't need a colpo. I've already notified 2 of my 6 patients next week. They don't need colpos. So it's really going to change things. And you can't do it in your head anymore. You could have gotten by without the app more or less before. You can't anymore unless you're good at memorizing Excel spreadsheets. So we bring her back in a year and let's look at 2 different results for her and see what they would do. If her PAP 1 year later, so again, she had her negative colpo, she had ascus HPV positive, now it's a year later, so it's 2 years post-colpo. If her PAP were totally negative, she gets to spread out to 3 years. So we avoided doing a second colposcopy, and this woman has cleared and she is good. Next slide. On the other hand, if at this second PAP post-colpo, she is ascus HPV positive again, now it's been persistent for 2 more years. It's long enough that now we need to take a look again. So that is that one. I'm wondering, let me see how we are on time. Okay, we're good. Let me ask people, is this working to see the app? Is this helpful? Because if not, I can jump over one section, or if it's useful to see it. All right, we got a helpful from Nikki. All right, unless I hear otherwise, I'm gonna keep going. All right, so let's take an example of, a good example of why you can't use the old app. We're gonna give identical results and see how it gives us a different result for 2 different patients. So next one. So we're going to take a 35-year-old woman who is ascus HPV negative. Okay, so let's take our first scenario. We're going to say that it's a routine screening result. She's had no prior abnormalities. So, you know, we pick the 30 to 65. We pick the management of routine screening results. We look at what it says, and it says follow up in 3 years because her risk is so low. Look at that 5-year risk of CIN3, 0.4%. Okay, now we're going to take that same result. That's good, you can split. So now we're going to take the same result. It's still a 35-year-old woman. She still has ascus HPV negative, but now we're going to give her a history of a leap for CIN3 in the past. Now, it's only ascus HPV negative. It's really a slight abnormality. However, her risk because of her history, although it doesn't hit the 4% threshold, it's more than the person who never had an abnormal, and she needs follow-up in a year. So again, pretty hard to memorize all this, that you need the app. Okay, next one. So let's take a moment and talk about something that I very briefly alluded to that is a pretty big change. So before, any PAP result you had with high grade led to colpo, and I'm going to show you an exception right now. So we're going to take a woman who's, again, we'll make her 35. That seems to be the chosen age today. So a 35-year-old person with a cervix comes in, gets a routine PAP. You get back a high-grade result. So next one on, yep. So HPV positive. So this is where I mentioned, you know, the earlier examples were showing untyped. Ours are always typed. So what you're going to select in that HPV is HPV positive genotyped. And here are the choices that you'll see, 16, 18, or other. So we're going to give this woman HPV 16 in high grade. Now, if you had asked me, if I'd asked any of you, what do you need to do? Your answer would have been, oh, she needs colposcopy. Next slide. So here's our confirmation, management of screening, HPV 16 with HSIL, and treatment. So this is a big change. Why? So if you look at HPV 16 in high grade, she has at least a 60% chance of CIN3, so she should go right to LEAP. Kind of interesting, right? Now I'm going to circle back to something I alluded to earlier. I had said to you that in this primary HPV screening, that one of the arms was 16, 18 positive, go right to colpo. The reason why it is better to reflex to cytology is if it's HPV 16 HSIL, then it isn't colposcopy. It's direct referral to GYN for a LEAP. So although you could go straight to colpo, you're going to end up needing to do a PAP at the colpo because so it's a little confusing. So really, if we do primary HPV screening, I think it needs to reflex routinely. So that's a big change. So that is memorizable. And in fact, it's so funny because really, you know, it's only a couple of weeks ago that I incorporated all this. And just last week, I had a MyChart staff message, not a MyChart, a staff message from one of our NPs who said, oh, this patient has HPV 16. She had a history of a LEAP. Should she go right to GYN? And I was like, yeah, news right off the press. She should. Now, we're going to take the same result, sorry, not the same result. We're going to now take high grade that isn't HPV 16. So same 35-year-old person with a cervix, management of routine screening results. We are going to give her HPV, but not 16-18. Next. So there it is, screening results, HPV other, not high risk, but not 16-18. And this is a little gray. So the risk of CIN3 in this patient is about 50%, 49%. So it's a conversation with the patient. So we had someone like this last week in Colpo Clinic and gave her the option. So what might influence it? So, you know, a LEEP is generally a very benign and well-tolerated procedure. And if the tissue removed is, I want to say it's less than 10 millimeters, but don't quote me, the risk of cervical incompetence or effects on pregnancies is exceedingly low, but it's not zero. So if you have a woman who has concerns for future pregnancy, it's very reasonable to do the colposcopy to confirm whether it is CIN 2 to 3 and what you need to do. On the other hand, if you have a woman who wants to do the minimum number of procedures and you know, maybe has dealt with abnormal PAPs before and is like, I don't want to keep doing these colpos, can I just be treated? You could refer that woman directly on. So it's a conversation. Next. Now, what about the patients who've had CIN 2 to 3? So let's take a minute, talk a little bit more about CIN 2 to 3. So CIN 2, which is basically moderate dysplasia, it is still considered high grade. In the US, traditionally, it's been treated with LEEP, but actually 40% of CIN 2 will resolve on its own. So we often, when patients have CIN 2, give them an option of monitoring and recolpoing in 6 months. But again, it's a conversation with the patient. Which would they rather do? Do they want to go CGYN and get this taken care of? Do they want to avoid a procedure and come back and see us for another colpo? So patients who have had treatment for CIN 2 or 3 or carcinoma in situ are in a much higher risk group, which makes a lot of sense. They continue screening for at least 25 years post the procedure. So in other words, if they were 50 when they had their CIN 3 and LEEP, they screen till 75. So they don't stop at 65. It all depends on when they had the treatment. What do I mean by at least 25 years? So if someone had a LEEP at 30, you're not going to stop screening at 55. You're going to take them at least to the 65. So it partly has to do with the age of the patient, and it partly has to do with the, you know, with the life expectancy. If you have a really hale and hearty 65-year-old with no health problems, and maybe her life expectancy is 90, you know, maybe she should keep screening to some random cutoff. So not clear. The screening is a co-test every 3 years. This is a change. The old app was once they went to normal was every 5 years. Now we go back to every 3 on the post-LEEP patients. So we do have patients whose problem lists right now are probably incorrect due to this change. If they have no cervix, it is a PAP of the vagina. You know, it's funny, I did one recently and I had trouble getting a good enough sample with the brush. And if anyone has spatulas still at their site, I need the old spatula to do a good vaginal PAP. Next one. So this is a graphic to try to pull some of this together. I've given you a few different ways this is laid out. So it's whatever kind of works visually from you. This is one of the slides from Dr. Zelig of GYN Onc. So again, the whole premise of where these clinical action thresholds fall is the risk of CIN3. So I'm going to start on the right-hand side, actually. So if the risk is more than 60%, so the immediate risk of CIN3, expedited treatment. If the risk falls between 25 and 59%, then it's this gray zone where you're going to assess patient preference. And that's generally going to be high grade ones that aren't 16-18. If it falls between 4% and 24%, it's going to tell you colposcopy. And so that's the risk, you know, of the finding CIN3. If the risk is between 0.55 and 4%, it's going to tell you 1 year. If it's between 0.15 and 0.54, it's 3 years. And if it's less than 0.15, it's 5. So if you're sort of wondering what those thresholds are, I think that that's really useful. And it makes sense. And it really, you know, particularly for the patients who we told them, you need a colpo, you know, every year if you have something abnormal, being able to frame this as this is why it changed, that your risk is so low that a colposcopy isn't needed this year, maybe next year. Next one. Make sure you think about some of these special populations. There is a special algorithm for pregnant patients. Again, someone who's symptomatic may be screened at a shorter interval. We already talked about the post-hysterectomy one. Patients under 25. So first of all, HPV is humongously prevalent, and most infections are transient, and most abnormalities will clear on their own. So really not too much has changed in that regard. The app does have a separate age 21 to 24. Barring high grade or ASK-H, those patients are usually just going to be monitored with an annual screening. Immunocompromised patients, a very important subpopulation, and they are on a different schedule. Our HIV providers can correct me, but I believe for the HIV patients, they talk about PAP smear screening starting 1 year after onset of sexual activity. So it might be before 21. If it's a new diagnosis of HIV, usually every 6 months PAPs for the first year and then annual. Remember to include in immunocompromised patients, patients who have had a solid organ transplant like a kidney transplant, and then patients on immunosuppressants. So IBD patients, RA patients, those patients may need to be screened annually. And then rarely screened patients, it's not so much they need a different interval. It's a reminder that most cases, over half of cervical cancer cases, happen in patients who haven't been screened. So these nuances of do we do co-test or HPV screening are important, but not anywhere near important as the issue of access to care and screening under-screened populations. Next one. So what are some of the essential changes? This is not everything on that one page I showed you, but it's a bunch of them. One is that colposcopy can now be deferred for some patients, particularly patients who've had a negative colpo before and have a mild abnormality now. And again, it's if their immediate risk of CAN3 is less than 4%. Expedited treatment, direct referral to GYN for high grade with HPV 16, and either expedited treatment or colposcopy for high grade with one of the other types. All primary HPV tests should be reflex to cytology because of this issue of the high grade HPV 16. And I will say, you know, we're having discussions about self-HPV screening, and there is some literature on it. You know, the self-collected samples, if they show HPV, the patient would then need to come in for a cytology sample, at least as it seems at this point, but more info to follow. Next slide.
There's a question, still just cytology for ages 21 to 25?
Yes, so 21 to 29 is going to be the cytology reflex HPV. So the testing isn't different, but the management of the abnormal results is different. So overall recommendations and conclusion, you do need the new app, which has a risk-based system of assessing patients' need for intervention or intervals. The thought is that because this is now risk-based, that if there are new tests or new evaluation tools, they could be plugged in based on their ability to assess risk, and that the entire guideline wouldn't need to be thrown out again in 5 years. Cervical cancer screening, diagnosis, management is really longitudinal, and you need to have your patient's history. You may have to get records and see what did their colpo show, what did their old PAP show, to really be able to interpret. There are a couple scenarios in the app where it comes up as clinical judgment. They're not common, but they're ones where there isn't enough data. And in those cases, you're going to talk to patients about colpo versus not and patient preference. Please remember to update your problem lists and to edit your health maintenance modifiers to reflect changed screening intervals if patient needs follow-up sooner than their age-based guideline. And think about getting all that history on the notes. Anyone who's seen a patient that we've colpoed knows there is an overview that has everything on it, including all our outreach attempts. So help on the problem list and make sure you get abnormal PAP diagnoses on there. And I think that's it. I've got some of the, on the next slide, I have some of the resources we used. And there's links there to the USPSTF guideline, as well as cancer statistics from the American Cancer Society, which I didn't really go into here, but are useful. And I think we're right on schedule and have time for questions.
Thank you, Dr. Karp. We did have a question come in. Any insight into how data is being used to push for coverage of HPV vaccine past age 27?
So, excellent question. So in November 2018, the recommendation came out that people 26 to 45, male, female, with or without a cervix, people, all people should be getting the HPV vaccine. It came out at the end of the year. So in 2019, insurance companies hadn't incorporated it yet. As far as I know, insurance companies are paying as of January. And I have been giving it. And in fact, I want to update the Colpo Smart Set to include counseling about the Gardasil vaccine. So this is another one where I think we're going to need to update our BPA and the Smart Set to incorporate that because that is key. The FDA let the Gardasil manufacturer provisionally also put an indication to prevent throat cancer. They are, it's provisional because they need more data, but it does look good. And again, it's because of the HPV and the throat cancer. So I would encourage people to offer that to people who haven't had it. The data by the time you get up to 45, the data is a lot weaker. The younger, the better really, which kind of makes sense. There isn't any data that giving the HPV vaccine helps people clear HPV who already have it. I try to be very clear to the couple patients about that. Although there is an interesting study that looked at people getting a LEAP for high-grade dysplasia, and they gave them the Gardasil vaccine or not. People who had the LEAP, who got the Gardasil, had a lower recurrence rate than people who didn't get the vaccine. So it does suggest some immunogenic benefit, but I think we can't say that for sure yet.
Sarah, it's Red. Can you hear me?
Yes.
This was exceptional. Thank you. And you raised a lot of interesting issues about attempts to individualize risk and surveillance, not only for this condition, but so I wanted to ask a couple of questions. One is, I guess I'm a little concerned about the decision tree being in an app and how we document that in the electronic health record. And it strikes me that, and this is sort of a question, whether this app can actually be incorporated into Epic, because it just seems like there's opportunities for transcription errors where you're basically going from a data that's in an electronic health record to something that's on your phone, and then you're sort of, how do you document that back into Epic? So just, and it, this idea of using data that's in Epic to help you manage and document risk in your choices would be something that would be really interesting. And just, again, because it's just, you're using a device that's sort of external to our health record. So I'm wondering how people have done this. And sort of the second question that would lead up to this is, how do we monitor our compliance with this as an organization? Again, when you're sort of identifying risk and making adjustments in terms of editing the frequency of screening and acting on this. So those are sort of two somewhat related questions of how do we document this going forward, and how do we monitor our quality performance around this?
Yeah, I've done, as I'm finding these patients who turn out not to need Colpo, I am putting on the problem list per 2019 guidelines so that I can even remember what my thought process was, or that if someone else looks at the chart, they can do it. We have the .ascvd that pulls in the ASCVD risk. I don't know if that can be done in Epic. I'm just thinking you could screenshot the treatment, the final slide in the app, and maybe pull it into Haiku. You can definitely, you know, from HICO, you can do a picture. I don't know if you can do a screenshot of your phone, but that would be interesting to do.
Really,
You know, or to
somebody-
document, you know, 0.5% risk of CIN3
Right.
based on ASCCP app.
Yeah, but maybe we could get Epic to sort of, I mean, this is an opportunity to sort of use some of the artificial intelligence in the system, you know, as we really individualize screening, surveillance, treatment.
Yeah, so I just comment that they've been very reluctant to do that because, you know, these guidelines change all the time. And, you know, it's a matter of documenting when you're looking at them. And Epic's basically been trying to avoid, they can't avoid it totally, but they've been trying to avoid real content algorithms and things like that because, you know, they're also, you know, as Sarah pointed out, there's also different organizations developing different guidelines. And so which guidelines are you using? And it's tricky. So I don't know if it'll get incorporated, but I think there's got to be a way to document it, as you said.
Dr. Nosel was just texting me that there's this PAP management section that we're not really using that's meant to support and document. So I can talk to her more about that and see that.
Thank you.
In terms of the editing the health maintenance modifiers, it is way underdone. That includes for colon cancer screening. I gave a talk to the interns and I actually gave them screenshots. I'm happy to share those screenshots from my cervical cancer screening talk with them because I think people are not using that. And it's really key because if you don't edit those modifiers and the resident graduates or the attending leaves or whatever, and someone else picks up the chart and it's not on the problem list and the modifiers aren't edited, you know, things get missed.
Thank you.
Dr. Karp,
I'm actually pulling up the chat too, Autumn, so now that I'm not talking, I can look at it. Ashley said she has seen preceptors taking screenshots of references on their phone. So yeah, that's exactly what I was thinking, Ashley, thank you. And then any information on non-HPV infection management and studies on increased risk of cancers. So 2/3 of cervical cancers are caused by HPV 16 and 18. The other third are caused by one of the other 12 high-risk types we do. So again, they're all high risk. So they have lower risk of cervical cancer, but they still have risk of cervical cancer. And studies on increased risk of cancers. I hope that answers that. You know, the huge question of how to clear HPV is one we have with patients at colposcopy. There's weak evidence for folic acid, 800 micrograms a day. So we suggest it to patients. Dr. Tietz and our integrative med colleagues there's a .cam HPV phrase. It has astragalus and new chapter life shield immunity mushroom capsules, which are thought to be immune boosters, but I'm very clear to patients that's not data driven. There's a weak evidence for turkey tail mushrooms for clearing HPV, whatever they are. Let's see if we missed any questions. Smoking cessation. So smokers are at higher risk of cervical cancer. We do recommend patients quit smoking, and that actually is in the .cam HPV phrase too. So yeah, that is definitely worth including in the conversation. I don't know if there's data on if you quit, how likely you are to clear. That's an interesting question.
And it doesn't change risk. In other words, it's not part of this app.
Yes, they don't use it for prediction, but we can say that smokers have a higher risk of cervical cancer. But yeah, it's interesting. It's not
family history.
So that's interesting too. Not in a direct sense, right? Because it's all HPV based. However, the question is, why do 90% of people clear HPV and 10% don't?
Exactly.
Maybe there are immune factors that relate to your risk for HPV to be persistent and then to put you at risk of cervical cancer. So in a sort of soft way. The other weird risk factor for cervical cancer that I don't even like to say is oral contraceptives. And if you go off them, the risk goes down. I don't know why that would be. And I even hate to say it. but apparently that's true. And then chlamydia infection may also be a risk factor. Maybe it's just because of STIs traveling together. I'm not sure.
Well, are there any other questions out there for Dr. Karp? All right. If not, we are at 9 a.m. Thank you so much, Dr. Karp, for sharing your
great.
expertise with us.
Yeah, thank you, Sarah.
Thank you.
Great.